Thanks, Lucy.
Okay, all right, thanks, Alex. So my name's Lucy Roebuck-Sayers. I'm a speech and language therapist working over here at Lancs Teaching Hospital. So I'm coming on to chat to you today about stroke swallow screening in Lancashire and South Cumbria. So I've got a presentation to present about our swallow screen and swallow screening in general, and then I'll open up the floor to any questions anyone has. I'm not sure in terms of discipline specific who we've got attending at the moment. Can we just turn off microphones and things just because I've got some background noise? Thank you. Okay. Okay, so going to start off with sort of what might be for some the sort of basics here of what is dysphagia. This might be a well-trodden path for quite a lot of us here working in stroke, but essentially all dysphagia is a difficulty with swallowing food, fluids or saliva. The most commonly quoted study that talks about dysphagia prevalence and is used actually in the National Clinical Guidelines for Stroke is from Martino et al. And they talk about incidence being estimated around 40 to 78% after acute stroke. It is sort of the most widely quoted study on this area of incidence, but it's got such a huge area because it tends to be in terms of how each study has rated that, the prevalence of it, what they've looked at, and dysphagia severity post-stroke. It's really important that we're looking at this and about swallow screening because the association between dysphagia and poor outcomes for the patient is quite high. There can be increased hospital stay, increased risk of chest infection, and a higher risk of mortality. Then looking at stroke recovery, it is anticipated that the majority of people with post-stroke dysphagia will recover. However, there are patients who will experience ongoing dysphagia for at least 6 months, and in some cases, especially those with more posterior or brainstem involvement, may have chronic impairment. So just for those who might not be aware, when we're looking from a speech and language therapy point of view at dysphagia, we look at the pre-oral, the oral and the pharyngeal phases of swallowing. So when we look at the pre-oral stage, we're thinking about the anticipation for eating and drinking. We're thinking about, can the person actually get the food and drink to their mouth to be able to start the act of swallowing off. And quite often a lot of that is just as important as anything else. So, you know, we all know ourselves when dinner time's coming up, we smell the food and we get that excitement and that anticipation of wanting to eat and drink, the saliva activation, and all of that is all involved in the pre-oral phase. In terms of the oral phase, then we will be looking at the muscles in the mouth, looking at the tongue, lip, looking at the movement, the manipulation of the food and drink and how that is controlled. Moving then towards the pharyngeal phase, so looking at essentially how is the food, drink, whatever it may be, saliva moved through the pharynx, through the throat, to be able to be swallowed safely and sort of pushed through into the esophagus and allowing adequate airway protection in its most simplest form. There is a fourth stage of swallowing that we look at in terms of the esophageal phase. However, that tends to be addressed more from our perspective from an upper GI or a gastroenterology team perspective. However, saying that, I'm sure as you can imagine, the act of swallowing is sort of one process, so any impacts on the esophageal phase will have in turn impact on the oral and pharyngeal phase also. But those are the sort of areas that we're looking at and what sort of is covered in the screen as well. So when we're looking at dysphagia, obviously we're talking about stroke and we're thinking about stroke, but it's just to sort of put out there that dysphagia can be found in other conditions. So for example, head and neck cancer, we can see that in frailty, in our frailty populations. So, you know, looking at prevalence of 50 to 75% of nursing home residents. We can have quite a high prevalence in COPD, for example. So 27% of those with COPD. We can have in terms of 68% of patients who experiencing dementia. And I mentioned before about between 50 and 60% of head and neck cancer survivors. So although we're looking at dysphagia in stroke, obviously stroke, it doesn't appear in its isolation in a person. They could have other comorbidities that impact their prevalence and their dysphagia risk, or the fact that they already have an existing dysphagia. So now I'm going to move on to why we looked at changing the Lancashire and South Cumbria swallow screen that we had in place. So we started this work with the clinical leads around about sort of 2.5 years ago now. So we looked to update the Lancashire and South Cumbria swallow screening tool, mainly for the reasons that we're putting across here that I'll explore in a bit more detail now. So we'd had changes in medical management. So we'd had the thrombectomy service that had been brought into practice, which now is of course 24/7 use, and that medical management wasn't even available when the first screen was made. There was a rise in stroke mimics across the pathway, making it more complex when we're looking at a patient screened using the original screening tool. And there was also a rise in patients who were not accepted under the stroke pathway and treated under the medical pathway that were being sort of lost lost through the net in terms of the traditional screening route, and were having unnecessary length of time nil by mouth within ED or other areas of hospital when they weren't accepted under the stroke pathway. Another reason was to standardise assessment considerations, so things like oromotor review, documentation of consent and documentation of completion, to standardise that up across the notes and how that is being considered. Another reason is because obviously, as we're well aware, within stroke, we are all about shared working across the network and with each other. So there was a high variability of practice across the Lancashire and South Cumbria region. In the different sites across the region, we had different swallow screens starting to take effect, and things being slowly but surely changed over the years. So the idea of the project was to bring all sites back together to have one swallow screen that was consistent across the patch, to be able to share the load of things like training, resources, and things like competency production and things like that. And also it was just an opportunity to invest and develop our nursing and MDT skills in the care of dysphagia and bring that more up to date. So now when we're looking at how the screen was changed. So first of all, we did, so I led on the project with the leads across the patch, and I approached the team at UCLan and we did a review of the evidence base and available swallow screens that were there. So we looked at completing what's called a rapid synthesis of evidence, and we it'll be on another slide, looked at the most recent Cochrane review that was completed, looking at all the swallow screens that were out on the market, for want of a better term, at the time of completion of that. So at the time of doing the review of the evidence base and available swallow screens, there were a couple of main things that were sort of brought up that I will touch upon in the next slide. Once we'd done that, we reviewed our own practice and decided to go about on a professional consensus to look at why we're using the swallow screen that we have in place, what considerations are out there, and what do we want to do in terms of our practice across Lancashire and South Cumbria. We did a review of the screen purposes and practices by that professional consensus. We updated the screen tool that we were using, and then we made a development of a new updated swallow screening tool with training and then with coexisting competencies. As part of that, we introduced a revalidation and retraining for all nurses using the screen to bring them all up to date and in line with the new screen, and also bringing in that sort of maintenance of competency. So what we were finding quite often is that we would have nurses that would approach us sort of saying, I worked in stroke, 5-10 years ago, I did the swallow screen then, I'm swallow screen trained, so I'm happy to complete the screen again. But what we've sort of brought back in with this new screening tool is that idea that actually, it's important just as any other area to have that maintenance of skill, maintenance of competency. Things do change, presentations change. We've seen a big change in terms of our stroke presentations across that time period. So there's an importance that actually we need to keep up that competence as well, especially if you've come from other areas or other regions using different screens. So when we looked at when we did the rapid synthesis of evidence, so we have a link to it, to the publication there that we produced. Essentially what it looked at was that across all the trials all the tools, the screening tools that we used, there was not one tool that had adequate, robust sensitivity and specificity to be able to identify risk of aspiration. There was, in terms of the studies that were completed, all studies had some form of issue within those areas. The other thing that was sort of highlighted within the Cochrane review and with the evidence base that was out there was that actually a lot of the screens were either screening aspiration risk or dysphagia risk. So thinking back to the slide that I showed you before, thinking about the pre-oral, oral and pharyngeal phase, that all encompasses a dysphagia. So there could be an impairment at one of those phases. However, an aspiration risk, when we're looking at those screens, it tends to be, say, 5 teaspoons of water or X volume of water. Is there any aspiration signs, yes or no? Now, the problem that we were sort of looking at when we had the expert consensus was that actually thinking about our region, thinking about the comorbidities and health needs across our patch and our patients, is that actually we have a lot of coexisting things such as COPD, head and neck cancer, and actually a lot of our patients are on modified diet and fluid consistencies already or experiencing a dysphagia when they're coming into hospital. If we had an aspiration only screen, and on our previous screen, some of those patients were being missed, and there were a few near misses where actually those patients who required a modified diet and fluid consistency were recommended normal diet and fluids. So those were some of the thoughts and considerations that were pulled together from this evidence base that took us forward into producing and updating our new screen. I suppose as well, a consideration to be transparent and open is that the guidelines advise that it should be a validated screening tool. So our screening tool that we're using in Lancashire and South Cumbria isn't a validated screening tool. The screening tools that were reviewed in the evidence base were all validated screening tools. However, it was agreed from the point of the expert consensus group that actually, because even though there are those validated screening tools out there, if there is concerns about specificity and sensitivity and our current tool is in place, do we look at updating what we have in place and being able to deliver that safely across the patch within the resources that we have at present? So that was the agreement that we made to sort of move forward with the current screening tool and look at more in-service quality improvement and review of that. Okay, so moving on to what swallow screening is and isn't. So swallow screening is required for all patients, as I think people might be aware, under the stroke pathway as per our national clinical guidelines. It has to be completed within 4 hours of clock start. A screen is that. It's not a detailed assessment of a patient swallowing, and it is used to identify early those patients who have a difficulty swallowing to try and minimise that risk of choking and aspiration with ongoing food and fluids and medication. Like anything, it is a snapshot in time, which I'll go on to when we look at the screen, why that's important. And it's an opportunity when we're doing our screen to identify other risk factors such as mouth care or other considerations that need to be put into place, such as facial palsy, things like that. And our screen is a screen that screens for the risk of aspiration and dysphagia. What it is not, it's not a replacement for our speech and language therapy assessment of swallowing. So it is a point of time at initial assessment during the stroke specialist nurse review or stroke nurse review, and then if there is a dysphagia identified, they would go on for further speech therapy assessment. It's not always appropriate to be completed, for example, with patients who have low GCS or who have active nausea or vomiting, but we do always put that it has been considered, and that would go down as a no but in terms of SNAP. And we're not able, in terms of our current screen, able to screen patients with complex morbidities or an existing dysphagia. So who screens in Lancashire and South Cumbria? So it is trust dependent due to different pathways. As we say, although we want to work together as much as possible to be able to streamline things across the patch, we have to acknowledge that we do have different setups in terms of, so for example, here at Royal Preston, we have the Royal Preston Hospital, which is our main stroke centre, but we do actually have GP admissions sometimes to Chorley Hospital and things like that. So there are differences across the patch. It's largely our stroke specialist nurses that complete, certainly at the Royal Preston, it is only our stroke specialist nurses, and I believe at ELHT as well, but it can be completed by the stroke nursing team dependent on trust setup. In terms of that, then we look at importance for maintenance of competency, and in terms of how frequently the screening tool is being used to be able to identify that risk of aspiration and dysphagia. And within that, we ask that competency must be reviewed if you're not completing the screening assessments regularly, just to make sure that, you know, the person completing the screen is able to appropriately deliver it and identify those most at risk. And that includes when moving between regions, as in moved up from down south or anything like that, that you would go through our training and have a look at our screen and have that signed off by one of our speech therapists. So in terms of what's been reviewed or changed when we looked at the new screening tool, so we introduced trials of solid diet textures to provide a more robust assessment. So previously only water was used, or water and yogurt, depending on the site. We had SLT standardised assessment for all patients post-thrombectomy due to the research that was coming out at the time. Sorry. In terms of risk of dysphagia post-thrombectomy. We added in the ability to repeat the swallow screen and clearer guidance to medical professionals because, as I'd alluded to initially in the initial screens, we were having some patients that were either stroke mimics or who were coming into hospital and not accepted under the stroke pathway that were placed nil by mouth and then were actually having a negative experience because they were remaining nil by mouth for extended periods of time unnecessarily because they may have been admitted for low GCS or nausea and vomiting at that time. So as part of the screening tool and training, we added in a more robust safety netting for those patients to be able to provide guidance for rescreening if the patient remains on the stroke pathway, or for more clearer guidance to the medical team in terms of that management of a dysphagia and when would be appropriate to refer to speech therapy. We added in standardisation of reviewing oral hygiene into the screen, and that being a prerequisite of consideration in our pre-screening. And we had additional considerations around cranial nerve function to allow more robust decision making at the moment of assessment. So this is the swallow screen that we use. I've got it on a different screen that I will show you. Just because I couldn't get it without it being quite blurry. So I hope that you can see this. But so we have a pre-screening section. Please do excuse my terrible IT skills that it's still got the Okay, I thought I'd thought something to get. I thought I'd figured it out to get rid of the guidelines, but sorry, it did not like that. So we have the stroke swallow screen pre-screening page. So with the considerations of, is the patient being treated for an active chest infection? Is there clinical suspicions for a brainstem stroke? Is the patient drowsy? And sort of it follows that route. Oh, sorry, can we just pop something? Can we just make sure we're on mute? So then it would follow the algorithm there to sort of move forward to give guidance in terms of how to follow the screen. Same if there is active vomiting or nausea, awaiting thrombectomy, if they already have modified diet and fluid recommendations in place at present due to the risk of a worsening dysphagia, or is there a previous history or requirement of oxygen. Thinking about the review of the oral cavity, is it clear the requirement to provide oral hygiene? Is it appropriate at that time? And if there isn't appropriate to complete, a consideration that it can be completed again, but that we would need to document that. Cranial nerve function and when we might discontinue. Considering significant facial weakness, mild to moderate, so increasing that guidance that we have there. And then if all of those areas are passed, sort of looking to continue with the screen. There we go. So then when we're looking at continuing with the screen, we would have a prompt there to check for any allergies. And then we would say that in terms of the swallow screen being used, that all parts of the screen must be completed to be able to pass the screen. If any part of the screen is failed, then it would be a fail of the full screen, place nil by mouth and referral to speech and language therapy. And just a prompt, the medical team or pharmacy review is advised in terms of critical medications whilst waiting review. So we would start with trials of water, move on to sequential sips, move on to a smooth texture, and then move on to regular diet. So a lot of this is quite similar to the previous screen that we had, and there was an updated list in terms of signs of aspiration. So things like, I'm sure you can appreciate, if there was no attempts to swallow or no swallowed trigger, then it would be an automatic fail. Water, saliva, diet residues leaking from the mouth, so significant weakness due to facial palsy. If there was cough during or post swallow, change to breathing pattern, wet or gurgly voice, food or fluid residue pooling in the patient mouth, choking or requirements of back slaps during the assessment. And one thing that we'd added in there was clinical judgment, sort of recognising that the nurses completing this, our stroke specialist nurses especially, are highly skilled and highly trained. And actually, if there is something there that's making them feel that it is an unsafe presentation and that they don't feel it would be safe to continue with diet and fluids, then actually that's just as valid that there may be a dysphagia present, and actually that there should be a fail with the patient placed nil by mouth. So that's looking at the screen that we have in place at present and that we are using. We have dysphagia swallow screening competencies that coincide with the screening tool that's used and with the training. Oh, that's very big, sorry. And so then where we're up to now is that we've done the publication, as we've said. We've finished the task and finish group, completed with the SLT clinical leads. I've completed the training package and scoped out the process for development into a blended learning package. So that would be with the idea that it would become an e-learning training that could be used across the trust. Currently, it is on PowerPoint, but that was while we were trialing the training across the patch, so that we knew if there was any changes that we wanted to do or anything like that. Our screen has been rolled out for all sites in Lancashire and South Cumbria. It's currently in use at Blackpool, ELHT, LTHTR. I believe due to staffing limitations in speech therapy, it's not been used at RLI and FGH, but the clinical leads were involved in the formation of the screen, the training and the competencies. And then we will be looking to review the use of the swallow screen and review the evidence base that we have in thrombectomy management, just to make sure that our screening tool is most up to date, because when it was brought into practice, this was all very new in terms of a service, in terms of thrombectomy management, and we've got lessons learned from having that service more established now and 2 years on, and obviously the opportunity for more gathered research evidence base in that area as well. So thank you for your time. Does anyone have any questions or anything they would like to ask about swallow screening or dysphagia in general? Hi there, Heather.
Hi there. Thanks very much for that, Lucy. That was really good to hear all about that. And thanks for all the work that you've done. So I'm from Morecambe Bay Trust, working in RLI and FGH. Lovely to meet you too. And only been in post as clinical and professional lead for coming up for 4 months. So kind of trying to see what's going on and how things are being run. But I just wondered how we could start training our nurses here and start rolling out the screen. How have you done that in other trusts, and how would we start?
Yeah, so it might be easier for me to get in touch with you separately, and we can arrange a time to meet and sort of go through that. But essentially, when I'd spoken to Tim and Abby, who were the professional leads in post at the time, I know that it's across your ED nursing team, isn't it, that do the swallow screening at the present time. We talked about lessons learned in terms of things like maintenance of competency, sign off, and the speech therapist being the final sign off, and we talked about practicalities for that. I think it's quite similar in terms of ELHT, LTHTR and Blackpool, I believe, in terms of how that would flow. I do believe there are some more specific challenges in terms of the number of workforce needing to be trained, but we can certainly have a chat about that and figure out a way to move forwards if that's okay.
Yeah, that'd be lovely. Thanks. Yeah.
We've also got Heather as well. Sorry, just to say hello. I'm just newly back from mat leave, but I've been trying to get in touch with somebody from RLI and FGH to invite them to our stroke SLT leads peer supervision if anybody would like to link in with that. So I can include with that as well.
There's no one in that post at the moment, but we're hoping to recruit into that post. But we do have 2 band 6s in stroke at the moment. So anyway, we can liaise further about that. Yeah. Thank you.
Thanks. Are there any other questions or anything that anyone wants to ask?
Would you be able to send the slides out to us by email?
I think they're going on the website, I believe. Is that right, Alex? I don't know why I jumped in to answer that question, Alex. You were far more qualified to answer that.
NHS Futures, as well as our clinical network website as well. But I mean, I can send them out, to the group who attended. Can I just ask anyone, we'll be sending out attendance certificates as well. So if you could put your email and contact details in the chat, that'd be great.
Thank you.
Elaine?
Lucy, can I just ask about the old dysphagia training pack that we used to have, the online one? Yeah. Is that no longer used by anybody now?
I believe that the website, that you couldn't get on the website, that physically the functionality of it. The last time I spoke to Tim at RLI, it would have been coming up to maybe 11-12 months ago. I think he'd managed to get on it, but it took quite a significant length of time for the website to load. As certainly as far as it is here at our trust, we've not been using it for quite a long time, and I do believe that's the same across the trusts, the other trusts.
Yeah, because it went out nationally, and I know that it's probably overloaded. It was an old website when we set it up. I'm just wondering, because obviously there's no point renewing it. I know that they were using it, and quite a lot of international people were using it as well.
Right.
So but I just So if I've not had anything back from them for a long time, so I just wondered whether we need to actually stop it and what have you, because we pay for that.
Yeah, my understanding is that it's not being used.
Okay.
And it wouldn't link in and link up with the current screen that's being used. I don't know whether Heather might be able to provide some more information at what's been used at FGH and RLI. I'm not as aware how that training is going at the moment, but I can certainly provide an update to you, Elaine, once we've met.
Yeah, no worries. That's not a problem. I'll just cancel it if that's going to be the case.
I think as well, just to make you aware, Heather, is that our training package is currently on the PowerPoint I think I mentioned this in the slides, whilst we were trialling it across the sites. I have been on maternity leave. I've just returned back, but also I was waiting for it to be trialed across all the sites in case yourselves had any changes that needed to be made, because we tried to obviously make it so that it could be used across all sites, but until it had been trialed everywhere, I didn't want to approach our blended learning team because then it would be sort of a more fixed package.
Yeah, of course. I mean, I'm really happy to start trialing it immediately, really, because we were actually looking, when I came into post with my new band 7, at looking at kind of changing the screen, and then this invite came through for this, so it's good timing.
Yeah, fab. We'll link in. But then Elaine, I will get back in touch with you about what the plan is once I've got in touch with blended learning, because that is the ultimate long-term goal.
No, just thanks for all your hard work on it, Lucy. I know it's not easy. With working it across the region is hard work, and and thanks to everybody for supporting Lucy. across the patch, because you know, it's a really worthwhile piece of work. Thank you.
Thank you.
Oh, and welcome, Heather.
Thank you. Nice to meet you all.
Right, thank you very much, Lucy. Right,
No
excellent
problem, thank you.
presentation. I don't know if there's any more questions, I don't think, so we can
Lovely. Okay, fab. Thank you
stop
very
the
much for your
recording.
time,
Thanks
guys.
very much.
Thank you. Thanks.
Thank
Bye-bye.
you. Thank you very much.
Bye,
Thank
everyone.
you.
Bye.
Bye.
Bye.